Biceps. The bicep becomes more prominent and more easily palpable when the elbow is flexed. Origin is the supraglenoid tubercle of scapula and the coracoid process of scapula. Insertion is the radial tuberosity. Action is flex the forearm and supinate the forearm. Innervation is musculocutaneous nerve. Deltoid. This muscle is highly palpable when arms is flexed, abducted, and extended. The origin of the deltoid is lateral one-third of clavicle, acromion, and spine of scapula. Insertion is deltoid tuberosity of humerus. Action is abduct, flex, and extends the arm. And innervation is axillary nerve. Pectoralis major. This muscle is highly palpable when arms is resisted into adduction. The origin of the pectoralis major is middle third of clavicle, front of sternum, costar cartilages of ribs 5 to 7. Insertion is lateral lip of bicipital groove. Action is adducts, flexes, and medially rotates the arm. Innervation is medial and lateral pectoral nerves. Trapezius. Hold the sloping superior lateral portion of the trapezius gently between your thumb and forefingers and palpate from its origin in the occipital region as it plays out into the clavicle and the acromion. Origin is the occipital bone, spines of C7 to T12, and ligamentum nuchae. Insertion is lateral one-third of clavicle, acromion, and spine of scapula. Action is retracts and rotates scapula, tilt head back, upper portions elevate scapula, lower portion can depress scapula, and innervation is cranial nerve 11. Triceps brachii. Have the patient lean on a table or desk as if he were supporting his weight on a cane or crutch. Since the triceps muscle is integral to the act of walking with a standard crutch, it will stand out prominently on the posterior aspect of the arm. Its origin is the humerus and infraglenoid tubercle of scapula. Insertion is olecranon of ulna. Action is extend forearm at the elbow, and the innervation is radial nerve. Rhomboids. Orient yourself for the palpation of the rhomboids by locating the smooth, triangular area at the middle border of the scapula. This area opposite T3 serves as the point of insertion for the rhomboid minor muscle. Origin is spine of T2 to T5. Insertion is vertebral border of scapula between spine and inferior angle. Action is retract and rotate the scapula, and innervation is dorsal scapular nerve. Rotator cuff muscles. Passive extension of the shoulder moves the rotator cuff into a palpable position. Therefore, holding the patient's arm just proximal to the elbow joint and lift the elbow posteriorly. Palpate the roundness of the exposed rotator cuffs slightly inferior to the anterior border of the acromion. The sit muscles cannot be distinguished from each other, but they can be palpated as a unit and near their insertion into the greater tuberosity of the humerus. Any tenderness elicited during palpation may be due to defects or tears, or to the detachment of the tendon of insertion from the greater tuberosity. Of the muscles of the rotator cuff, the supraspinatus is the most commonly ruptured, especially near its insertion. Spine of scapula. Palpate first the C7 vertebra, then run down to T3 vertebra and palpate laterally to feel the spine of the scapula. Greater tuberosity of the humerus. Internal and externally rotate the arm to feel a hump or a bump in the shoulder. Internal and external rotation of the arm causes the greater tuberosity to move posteriorly and anteriorly into the glenoid fossa of the scapula. The coracoid process. Palpate first the clavicle, then run down laterally to feel a hump, then go inferiorly to feel the coracoid process. The acromion process. Palpate first the greater trochanter, then go upwards to feel the acromial end. Medial epicondyle. The medial epicondyle is located on the medial side of the distal end of the humerus. It is rather large and subcutaneous, and its bony contours stand out conspicuously from the surrounding tissue. Medial supracondylar line of the humerus. Move upward in linear fashion from the epicondyle and palpate its short bony ridge. Even though it's covered by a thick origin of the wrist flexor muscles and is not very distinct. Olecranon. The olecranon is a large process in the upper end of the ulna. It is conical in shape and has a relatively sharp apex which is covered by loose tractable skin that permits extreme elbow flexion. Flexion moves the olecranon out of the depth of his fossa, making it available for palpation. Lateral epicondyle. Located lateral to the olecranon process is the lateral epicondyle. It is prominent but somewhat smaller and less defined than medial epicondyle. Lateral supracondylar line of the humerus. This is better defined and longer than the medial supracondylar line, extending almost to the deltoid tuberosity. From the lateral epicondyle, palpate up the lateral supracondylar line and then back down to the lateral epicondyle. Radial head. With the patient's arm abducted, ask him to maintain his elbow flex in position. To orient yourself, relocate the lateral epicondyle and move your fingers about 1 inch distally until you find a visible depression in the skin just medial posterior to the wrist extensor muscle group. The wrist flexor pronator muscle group. Pronator teres. This muscle is covered by other muscles and is not distinctly palpable. Flexor carpi radialis asks the patient to make a tight fist and then to radially deviate and flex his wrist. The flexor carpi radialis stands out radial to the palmaris longus and may be palpated proximally towards its origin. Palmaris longus asks the patient to do an opposition and trace down the tendon superiorly. Flexor carpi ulnaris. Even if the patient makes a tight fist, this muscle will be less prominent than the palmaris longus or flexor carpi radialis, but it does stand out slightly into the ulnar side of the palmaris longus. Olecranon bursa. The olecranon bursa covers the olecranon and is not distinctly palpable. However, the area in which it lies should be palpated. If the bursa is inflamed, the area will feel baggy and thick. Extensor carpi radialis longus and brevis. To make these muscles prominent, have the patient make a fist as you offer resistance to the dorsum of his hand. Wrist extension accentuates the contour of these muscles at the wrist, just proximal to the second and third metacarpal. The origin of these two muscles are lateral supracondylar ridge and lateral epicondyle of the humerus. Insertion is the base of second metacarpal and base of second and third metacarpal bones. Action is extends and abducts the hand at wrist. Innervation is radial nerve. Brachyradialis. To make this muscle more prominent, have the patient close his fist, place in a neutral position under the edge of the table and then lift up against the weight of the table. Origin is the lateral supracondylar line of the humerus. Insertion is distal radius. Action is flexed forearm at the elbow. And innervation is radial nerve. Biceps tendon. The biceps tendon and its muscle belly become more accessible to palpation if the patient places his closed fist under the edge of the table and tries to lift the table. Brachial artery. The pulse of the brachial artery can be felt directly medial to the biceps tendon. Median nerve. The median nerve is a round tubular structure lying directly medial to the brachial artery. In its course, it leaves the elbow distally and pierces the pronator teres muscle as it enters the forearm. Musculocutaneous nerve. This nerve lies on the lateral side of the biceps tendon and provides sensation for the forearm. Radial styloid process. The radial styloid process is truly lateral when the hand is in the anatomic position. The anatomic snuff box. The anatomic snuff box is a small depression located immediately distal and slightly dorsal to the radial styloid process. It becomes outlined and it's palpable when the patient extends his thumb laterally away from his fingers. Navicular. The navicular, also known as the scaphoid bone, is situated on the radial side of the carpus. It represents the floor of the snuff box. The navicular is the largest bone in the proximal carpal row. Ulnar deviation causes the navicular to slide out from the under the radial styloid process so that it becomes palpable. Trapezium. The trapezium is located on the radial side of the carpus where it articulates with the first metacarpal. Move distal to the snuff box to palpate the trapezium or the first metacarpal articulation. Tubercle of radius or Lister's tubercle. Lister's tubercle lies about one-third of the way across the dorsum of the wrist from the radial styloid process. It feels like a small longitudinal bony prominence or nodule. Ulnar styloid process. Return to the basic position with your fingers on the ulnar and radial styloid process. Note the ulnar styloid process does not extend far as distally as does the radial process, and that is more prominent than thicker than the radial counterpart. Triquetrum. The triquetrum lies just distal to the ulnar styloid process, in the proximal carpal row. To facilitate its palpation, the hand must be radially deviated so the triquetrum moves out from the under the styloid process. Pisiform. As you probe the anterolateral region of the triquetrum, you will feel a small sesamoid bone, the pisiform, which is formed within the flexor carpi ulnaris tendon. First metacarpal. The first metacarpal should be palpated for continuity in bone structures from the anatomic snuff box to the metacarpophalangeal joint. Metacarpophalangeal joints. Move distally from the metacarpals and palpate the fusiform joints while they are flexed so that their articulation are exposed. Phalanges. There are 14 phalanges on each hand since the thumb has 2 and the other fingers have 3 each. The proximal and middle phalanges articulate in the proximal interphalangeal joint and the distal and middle phalangeal joints at the distal interphalangeal joints. Occasionally, you may find one finger palpably different from the others of the same hand as well. Tunnels of the hand. Tunnel 1 is the abductor pollicis longus and extensor pollicis brevis. Tunnel 2 is extensor carpiradialis longus and brevis. Tunnel 3 is extensor pollicis longus. Tunnel 4 extensor digitorum communis and extensor indicis. Tunnel 5 is extensor digiti minimi and tunnel 6 is extensor carpi ulnaris. The thinner eminence. It is composed of three muscles which activate thumb in motion: the abductor pollicis brevis, opponens pollicis, and flexor pollicis brevis. Hypothenor eminence. This eminence is composed of three mobile muscles: the abductor digiti quinti, the opponens digiti, and the flexor digiti quinti. Palm. The structures within the palm are not distinctly palpable because of the thick muscle padding. The anterior superior iliac spine. Stand in front of the patient and place your hands upon the sides of his waist with your thumbs on the anterior superior iliac spines and your fingers on the anterior portion of his iliac crest. In thin patients, these bony prominences are subcutaneous, but in obese patients, they are covered by adipose tissue and may be somewhat more difficult to find. Iliac crest. The iliac crest is subcutaneous and serves either as a point of origin or of insertion for a variety of muscle. None of these muscles cross the linear crest and it remains available for palpation. Posterior superior iliac spines. These are easily located for they lie directly underneath the visible dimples just above the buttocks. Greater trochanter. Keeping your thumb upon the posterior superior iliac spine, move your fingers downward and you can again palpate the posterior aspect of the greater trochanter. Ischial tuberosity. The ischial tuberosity is located in the middle of the buttocks and approximately level of the gluteal fold. With your fingers in place upon the greater trochanter, move your thumb from the posterior superior iliac spine to the ischial tuberosity. Femoral triangle. The femoral triangle is composed of inguinal ligament, femoral artery, femoral nerve, femoral vein, sartorius muscle, and adductor longus muscle. Hip and pelvic muscles. Flexor grouping is composed of iliopsoas muscle, sartorius muscle, and rectus femoris muscle. The adductor grouping is composed of the gracilis, pectineus, adductor longus, adductor brevis, and adductor magnus. Abductor grouping is composed of gluteus medius muscle. Then extensor grouping is composed of gluteus maximus muscle and hamstring muscle. The patella. The patella is fixed in the trochlear groove in the flexion and mobile extension. Thus, the medial and lateral portions of the patella's undersurface are much more accessible to palpation when the knee is extended. Infrapatellar tendon. The infrapatellar tendon lies just inferiorly to the patella. Medial and lateral femoral condyle. As you move your thumb upwards, you will find the medial and lateral femoral condyle, part of which is palpable immediately, medial to the patella and lateral to the patella. Medial and lateral femoral epicondyle. The lateral and medial femoral epicondyle lies lateral and medial to the lateral and medial femoral condyle. Lateral and medial tibial plateau. Push down with your thumb into the soft tissue depression until you feel the upper edge of the lateral and medial tibial plateau. Palpate it along the sharp edge to the junction of the tibia and femur. The head of the fibula. From the lateral femoral epicondyle, move your thumb inferiorly and posteriorly across the joint line. The fibular head is situated at about the same level as the tibial tubercle. Quadriceps muscle. Quadriceps muscle become more prominent upon isometric knee extension. It is composed of four muscles: rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. For the rectus femoris muscle, origin is anterior inferior iliac spine, insertion is patella and tibial tuberosity through the patellar ligament, action is extend leg at the knee and flex thigh at the hip. Innervation is femoral nerve. For the vastus lateralis, origin is greater trochanter of femur and lateral lip of linea aspera. Insertion is patella and tibial tuberosity through the patellar ligament. Action is extend leg at the knee. Innervation is femoral nerve. Vastus medialis. Origin is intertrochanteric line, medial lip of linea aspera. Insertion is patellar and tibial tuberosity through the patellar ligament. Action is extend the leg at the knee, and innervation is femoral nerve. Vastus intermedius is the origin is the shaft of femur. Insertion is patella and tibial tuberosity through patellar ligament. Action is extends leg at the knee, and innervation is femoral nerve. Pes anserine bursa. The pes anserine bursa is located between the tendons of the sartorius, gracilis, and semintendinosus muscle, and the upper medial aspect of the tibia, just medial to the tibial tubercle. It is not palpable. However, if it becomes inflamed, you may be able to feel some effusion and thickening. Biceps femoris tendon. When the knee is flexed, the biceps femoris tendon becomes prominent where it crosses the knee joint before inserting into the fibular head. The iliotibial tract. The iliotibial tract is situated more anteriorly on the lateral aspect of the knee. It is palpable to the point where it inserts into the lateral tibial tubercle. The iliotibial tract is neither a muscle nor a tendon, but rather a long, thick band of fascia. The popliteal fossa. The popliteal fossa is composed of the posterior tibial nerve, popliteal vein, and the popliteal artery. Gastrocnemius muscle. The two heads of this muscle are palpable at their origin on the posterior femoral surface, just above the medial and lateral condyles, where the patient flexes his knee against resistance. Its origin is the medial and lateral condyles and posterior surface of femur. Insertion is unites with the tendon of soleus and forms calcaneal tendon. Action is plantar flexion of the foot, and innervation is tibial nerve. The medial malleolus. The medial malleolus from the head of the talus probe proximally until you come to the prominent medial malleolus. Sustentaculum tali. Move plantarward approximately a finger's breadth from the distal end of the malleolus until you find the sustentaculum tali. Medial tubercle of the talus. The medial tubercle of the talus, which is small and barely palpable, is immediately posterior to the distal end of the medial malleolus. Medial aspect of the foot. Head of the first metatarsal bone and the metatarsophalangeal joints. The head of the first metatarsal bone and the metatarsophalangeal joint are palpable to the ball of the foot. First metatarsocuniform. The metatarsal flares slightly at its base and meets the first cuneiform bone to form the first metatarsocuniform joint. Navicular triangle. As you continue moving proximally along the medial border of the foot, the next large bony prominence you encounter is the navicular tubercle. The head of the talus. The medial side of the talar head is immediately proximal to the navicular. You can find it by inverting and everting the forefoot. The resultant motion between the talus and navicular is palpable. The lateral aspect of the foot. Fifth metatarsal bone, fifth metatarsophalangeal joint. These are situated in the lateral side of the ball of the foot. Calcaneus. Move proximally along the foot's lateral border to the calcaneus, which is subcutaneous and easily palpable. Peroneal tubercle. The peroneal tubercle lies on the calcaneus distal to the lateral malleolus. Lateral malleolus. The lateral malleolus, located at the distal end of the fibula, extends further distally and is more posterior than the medial malleolus. Sinus tarsi. Stabilize the patient's foot and calcaneus with one hand and place the thumb of your free hand into the soft tissue depression just anterior to the lateral malleolus. The depression lies directly over the sinus tarsi, which is filled by the extensor digitorum brevis muscle and overlying of fats. Dome of talus. Keep the patient's foot in inversion and plantar flex. A small portion of the dome of talus becomes palpable. A great portion of his surface is palpable on its lateral side than on the medial side adjacent to the medial malleolus. Inferior tibiofibular joint. This joint lies immediately proximal to the talus, since the anterior inferior tibiofibular ligament overlies this joint. Cleared palpation of the joint itself is impossible. However, you can feel a slight depression directly over it. Area of the hind foot. Dome of the calcaneus. The bare posterior third of the dome protrudes sharply from behind the ankle joint. As you move plantarward along the walls of the calcaneus, notice that the bone flares outward at its plantar base. This flare may become excessive following a compression fracture of the posterior third of the os calcis. Medial tubercle. The medial tubercle lies on the medial plantar surface of the calcaneus. It is rather broad and large and gives attachment to the abductor hallucis muscle medially and the flexor digitorum brevis muscle and the plantar aponeurosis anteriorly. Head of the first metatarsal bone. The area surrounding the prominent head of the first metatarsal bone and first metatarsopalangeal joint is the site of the common pathologic condition hallux valgus. The metatarsal heads. Move laterally and palpate each metatarsal head by placing your thumb upon the plantar surface and your index finger upon the dorsal surface of the foot. Metatarsophalangeal joint, the navicular tubercle, and the talar head. The deltoid ligament, tibialis posterior tendon, flexor digitorum tendon, posterior tibial artery, and flexor hallucis longus tendon. The dorsum of the foot between the malleoli, tibialis anterior tendon. To make palpation of the tibialis anterior tendon easier, instruct the patient to dorsiflex and invert his foot. The tendon should then become quite prominent where it crosses the ankle joint. Its origin is the lateral condyle and surface of tibia. Insertion is medial cuneiform and first metatarsal. Action is dorsiflex and invert the foot. Innervation is the peroneal nerve. The extensor hallucis longus tendon. This tendon is situated immediately lateral to the tibialis anterior tendon and becomes most prominent when big toe is actively extended. It stands out immediately lateral to the tibialis anterior tendon and the level of the ankle joint. The origin is the anterior surface of fibula and interosseous membrane. Insertion is distal phalanx of great toe. Action is dorsiflex and invert the foot, extend great toe, and innervation is the peroneal nerve. Extensor digitorum longus tendon. This tendon lies lateral to the extensor hallucis longus. Palpate it first when it crosses the ankle joint. Distal to the ankle, the tendon divides into four parts, each of which inserts into the dorsal base of the distal phalanx of the four lesser toes. Its origin is the lateral condyle of tibia and surface of fibula. Insertion is medial and distal phalanges of toes 2 to 5. Action is dorsiflex and invert foot, extends toes 2 to 5, and innervation is the peroneal nerve. The dorsal pedal artery. The dorsal pedal artery lies between the extensor hallucis longus and the extensor digitorum longus tendons. The anterior talofibular ligament, the calcaneofibular ligament, and posterior talofibular ligament. The plantar surface of the foot. The antalgic gait. The ataxic gait. The circumduction gait. The hemiplegic gait. The steppage gait. The unilateral gluteus medius gait. The bilateral gluteus medius gait, also known as chorus girl. The Parkinsonian or shuffling gait.